Shut off Myers to pick up Scarlet Myers is out until week 9.
Conjunctivitis?
So it's deep. Generalizing.
Trying to trade it
D, right?
Swift is
Remember we talked about hypothyroidism, they have that neurological edema, that treatment before it controls the fibroblasts.
you can do
Versus
the
hypothyroidism, that's that pre-tibial edema. Coming back.
I don't think Myers keeping it 7 points.
Exactly. Nice.
So pick your Joe back up, pick your shirt, do this stuff.
Okay.
Touch the Apple.
Here's some good choices. Some people say C.
Lost this one.
Ooh. Gotcha.
You guys remember? No, you won't. Exogenous glucocorticoids. That's going to cause Cushing syndrome. So we're giving this to people. If they have a tumor in the pituitary gland, it's making too much ACTH, then that's the Cushing's disease. Looks the same, right? Same process essentially. Somebody said C. Why is it not C?
We need more.
Need more. I give you more. I give you more.
Oh, no, not for the question, like the ACTH. This was perfect. More questions like this.
Gotcha. All right,
More
guys.
questions? Insufficient adrenal.
All right, I'm seeing some good signals to me. That's right. That's what we essentially talked about, where the immune system starts attacking the neural cortex. So we're not gonna be making corticoids. Also aldosterone, we'll talk about that too, right? All right, guys. Good job. All right, so the skin. You're definitely going to see a lot of skin issues when you're out there. We're going to talk about, just quickly go over some A&P stuff, just to kind of refresh your memory from last semester. Talk about some dental markings, moles, and things like that. Types of injuries you can receive to the skin, infectious diseases, and then some idiopathic things that you might see, and then obviously cancer. That's the big thing we're worried about when we talk about skin. Just a quick recap. So epidermis, right? That's that outer layer of the skin. There's multiple layers to the epidermis. You got multiple layers. They're composed of keratinocytes. That's what they are, and their job is to make keratin, and that keratin is protective. It's a protein that makes that skin firm, makes it resistant against abrasions and injuries. We got the melanocytes. Their job is to make melanin. That's what gives people their skin tone. Everybody has melanin, right? Everybody makes melanocytes. everybody has the same amount of melanocytes. The difference is that some of these melanocytes make more melanin than others, and so that's why people have a differing skin tone. And that melanin is protective. That melanin helps protect us against UV light, because that UV light can damage the nucleus of that keratinocyte and potentially lead to mutations, potentially cancers, right? So we definitely want melanin. We've got the dermis, that's that deeper layer, and that's where our blood vessels are, that's where our hair follicles, our sweat glands, and there's different kinds of sweat glands. There's the eccrine sweat glands. They help us, they make us sweat. We want to sweat because when we're too hot and we sweat, that helps us evaporate that heat. We also got apocrine glands or odoriferous glands. Those typically develop later on, or they're there, but during puberty, they respond to our hormones. And they make this compound that bacteria can then metabolize, and that's what gives it that odor. They're typically found in the axilla and in the groin. And the hair follicle, the sweat glands, and the odoriferous glands, those are our skin appendages. So those are what are termed our skin appendages. And they're useful because they have keratinocytes as well. And so if we have damage deeper to that dermis, those keratinocytes that are in those skin appendages, they can actually proliferate, help us fix that damage, right? To hopefully prevent us from scarring. Blood vessels, we talked about that. Nerve endings as well. That's what, touch, pain, all that kind of stuff. Those are located in the dermis. And then the hypodermis, that's that deeper layer under the dermis. And that's where we store fat, right? And we use that fat later on for energy. It's also got connective tissue to help anchor down that skin to the muscle and the fascia. So we want that stuff there. All right. The skin, obviously, is not sterile. You guys know that there are bacteria there. We want that bacteria there that helps protect us against other types of bacteria and fungus growing. So it's protective. But sometimes when we get breaks in the skin, that bacteria can get into our skin and cause infection. Skin protects us. Definitely, it's a barrier. We don't want things getting into our body, so we want our skin barrier there. It also is very important for protecting us against the heat and cold, right? We talked about sweating. If we're too hot, then we're going to sweat. If we're too cold, our vessels are going to dilate in that dermis to try to bring that blood back to our cord. Immune reactions, so you can definitely see immune reactions at the skin. We talked about contact dermatitis. Our first block, we'll talk about a little bit more today. We can see skin manifestations from diseases like the thyroid, prepubital lymphedema, that kind of stuff. Diabetes, we're going to see if we have a low immune system from diabetes, we're more prone to developing infections. We can develop ulcers as well. But the most common, the thing we care about a lot, right, are cancers, because our skin is exposed to all types of UV light, different types of chemicals, those chemicals, that UV light can damage those skin cells, essentially turn them into some type of malignancy. We'll talk about it for you. All right, so in dermatology, or when you guys are out there practicing, we have to describe things, right? We have to describe things to other people, other providers that we're trying to maybe refer a patient to, or we just want to make sure that we're documented in a way that the person who comes behind us knows what we're saying, right? So we do a lot of we use a lot of descriptive terms in dermatology. So a macule. A macule is just a flat lesion, and it's up to 2 centimeters in diameter. So when you touch this thing or when you see it, you're not going to feel any type of raised lesion. You're not going to be able to feel it. It's going to be flat. A patch is very similar to a macule, except that it's bigger. Don't let the color confuse you. I know the macule, I'm showing you a mole right there, and then down below I'm showing you hypopigmentation or vitiligo. All we're trying to describe is just the way it looks, right? So a patch is just a bigger macule, if you think about it that way. A papule is an elevation less than 1 centimeter diameter. So you're going to be able to feel this thing. When you touch that skin, it's going to feel like a raised bump. A nodule is bigger. It's essentially a bigger papule. It's 1 to 5 centimeters in diameter. And then above that, we start calling those tumors. But tumor doesn't mean cancer, right? Tumor just means growth. And so it could be cancerous. It might not be cancerous. It's just, we're talking about the size there. Vesicles, so these are fluid-filled elevations of skin up to 1 centimeter. And we kind of briefly talked about vesicles during our first block. We talked about serous inflammation. These are just filled with serous fluid. A bully, these are bigger vesicles, right? They're bigger than 1 centimeter. This is more inflammation going on here. They're just bigger. A pustule is a vesicle filled with pus. So in that vesicle, we're starting to get immune cells. We're starting to get white blood cells. Maybe they're dying. Maybe there's bacteria in there. So this is just pus, right? And then a widow, these are elevated, itchy, transient lesions with erythema. So these are hives. These are localized inflammation in the dermis. Mast cells are kicking in. They're causing that histamine, which is increasing that vascular permeability. And so we're getting this interstitial fluid in the dermis. These come and go. These are what hives are. Excoriations. So these are from scratching. So superficial injury to the skin from scratching. And these are people who develop these. They're scratching a lot. And it could be from a number of things. It could be from contact dermatitis. It could be from scabies. It could be from anything that causes the skin to itch, and the patient's going to scratch, and they're scratching so much that they're starting to damage that skin. Okay? So our job is to figure out why that's the case, and way we can stop that. Because with excoriations, you worry about secondary infections. If your fingernails are dirty, you scratch, you introduce bacteria, and then those can develop into infections. Ulcers, these are just focal losses of epidermis and dermis. So a lot of things can cause ulcers: pressure, diabetes. We're breaking down that epidermis, breaking down that dermis. Potentially can go down to that sub-Q layer. Again, our job is to figure out what's causing that and to stop it. Crusts, these are essentially, this is the skin covered with blood or serum. So very, very common in impetigo, which we'll talk about today. When you get this infection, you get pustules that develop. When they rupture, that serous fluid in it, it's going to leave this kind of crusting residue on the skin. Scales, these are excess dead epidermal cells, so skin flakes, right? You can easily remove these. This is dandruff, or this is something that causes increased amount of keratinocytes to proliferate and we can, we touch them, they start sloughing off. Seborrheic dermatitis, which we'll talk about today, is very characteristic for this. All right, so congenital markings. So we're going to talk about moles, right? Melanotic nevus and then nevus flammeus. So congenital melanocytic nevus, these are moles. These are, kids can be born with these, right? I was born with one right here. I got this guy. It hasn't changed, thankfully. All they are just melanocytes that are in these nests, just a collection of melanocytes. And they can occur really anywhere in the epidermis or the dermis. We're not going to kind of get into where they're at, but just know that they can be in the epidermis or the dermis. They're present at birth. Typically, we're going to see them right away. They may pop up a few days or a few weeks or a few months later on, but they're there. They're melanocytes that are just in this collection. Most of the time, when they look small, normal, benign, we just monitor them, right? As long as they don't change, because it really depends on the size of them, but we won't get into that detail. As long as they don't change, we just watch them, and most of the time people have these and there's no problem. Nevus flammeus, this is not a mole, right? This is not a melanocyte issue. The problem here is that these people are born, we have capillaries, right? Capillaries are deep below, and most of the time they're constricted. For these folks, there's a collection of capillaries that are not constricted. So they have a permanent dilation. Because of that, they're more engorged. So you can see those capillaries through the skin. The thought process behind this is that they think that for some reason these capillaries, they don't get that sympathetic innervation. They don't have those nerve fibers like normal capillaries do. And so because they don't have that, they're more engorged and more dilated. Most of the time, they're no issue, right? For some people, it causes cosmetic issues, but they're not going to turn into cancer. They're not going to cause any issues. They're not going to clot with blood and cause some type of blood clot. They're just dilated capillaries that we can see under the skin. Most of the time, they occur on the face. They're well demarcated, which means that you can see where they start and stop. They're not kind of flushing into the skin. They look red, purple, just depending on how much dilation is going on. All right, so external injuries. Kind of more terminology. So because the skin is exposed, right, we're prone to damaging the skin. We can, throughout the day, you are exposing your skin to all kinds of things. Maybe you hit the doorknob, maybe you fall and bust your knee. Your skin, but it's there to protect us. We want that skin there because if not, things can get in. An abrasion, contusion, and laceration, these are typically from blunt force. So abrasion is a superficial scraping of the epidermis. So we scrape off the epidermis, we can most of the time see the dermis, but the epidermis is where the problem is. So you fall, you scrape your knee, that's an abrasion. A contusion is just bleeding under the skin, right? Bleeding in the dermis. There's some type of blunt trauma to the skin. It wasn't enough to actually break the skin barrier, but the vessels under the dermis, they broke, so now they're bleeding into the dermis, and so you see this dark, kind of purplish looking bruise. Over time it's going to go away as the body starts to clear it, but that's all a contusion is. The laceration, this is a jagged tear through the skin, typically due to more of a forceful blunt trauma. So think about your boxers or your UFC fighters or things like that, right? They get punched, that skin busts, right? That's a laceration. The skin normally has tensile strength from the collagen, and when that force overcomes the strength of that tensile strength, it can cause that skin to lacerate. And so typically they're jagged, so they're harder to kind of treat, harder to close up, but it's just that force that's causing that tear. Incision and puncture, these are sharp forces. So think about your scalpel whenever you do a procedure on a patient, you cut them, right? Or maybe they get cut by glass, or they get cut by something sharp. These are typically straight, very easy to typically suture up and clean up. Puncture, these are more deeper wounds caused by a sharp, thin object. And these can fool you, right? Because think about it, you got something thin that goes into the skin. When you look outwardly, it doesn't look that bad. It's going to be a small little, injury, but the problem is deep, right? You went deep into the skin, you went deep into the dermis, potentially went into the muscle. And so if you have some type of exposure from puncture injury, maybe a cat bit you, which you guys, I think I told you guys how to feel about cats. I got a cat, but go ahead. They're dirty too. They got dirty mouths, but all that stuff is getting into your skin, right? And so you're at risk of developing an infection. So don't let those fool you. If something punctures the skin, you gotta be careful because these are at high risk for infection. So examples: abrasion, contusion, laceration, incision. And look at those punctures, right? They don't look that bad on the outside, but it's that deep process that you're at risk for having that infection. You gotta be careful. All right, so thermal injuries, so burns, right? I know this slide is a little busy, but I think it's kind of easy to try to kind of put into perspective, to try to understand. So we got first degree burns, these are superficial burns. We got second degree, we got superficial partial thickness. Second degree again, but this is a deeper partial thickness, so deeper burn. And then third degree burns, which are full thickness. And let me just try to hopefully make this easy to understand. So first degree burns, this is where the epidermis is burned. This is classic for your sunburns. So people who have sunburns, this is what they develop. That thermal injury only affects the epidermis. So the underlying dermis is not affected, right? You still have blood flow, you still have those blood vessels, but there's inflammation that occurs with this, and so you're going to have some erythema. It's going to be red because inflammation sets in, causes that vasodilation, and the epidermis is injured, and so you're going to see some erythema. When you push on it, because those blood vessels are still intact, you're going to have blanching, right? You're going to have that white kind of leftover when you push on it, and you let go, and then the blood's going to rush back in. The skin is intact, right? The dermis is still intact. There's no break in the skin. It's just the epidermis is injured from that thermal injury. It's going to be painful because you have nerve cells in that dermis, and when you cause inflammation, it's going to activate those nerve cells, and it's going to cause pain. It's going to be painful. And most of the time, within a week, you're going to get better. There's not going to be any scarring because that dermis hasn't been affected. The second degree superficial partial thickness burn, this is where the epidermis and the superficial dermis is damaged. But look, the skin appendages are intact. So the hair follicles, the sebaceous glands, the sweat glands, they're still intact. They're not damaged. When you have these types of burns, you're going to see erythema. And remember I talked about in the first block with second-degree burns, you're going to have blistering. It's more of an inflammatory response, so you're going to see blisters with these guys. It's going to be moist because that inflammation, you're going to have more capillary permeability, so that you may see some type of exudate on the skin, not exudate, but moisture from the fluid coming out. The blood vessels are still intact, so when you push on it, there's going to be blanching. So they're not injured, so you push on it, there's going to be blanching. The thing with this is that it's still painful. It's very painful. It's actually more painful because now the dermis is exposed, those free nerve endings are exposed. This is more painful than your first-degree burns. Typically heals within 1 to 3 weeks. Scarring is unusual because those skin appendages are still intact. And they have those keratinocytes, and so they can proliferate and cover up that defect. When you get to second-degree deep partial thickness, this is where the epidermis and most of the dermis is destroyed, it's damaged. You may still have some skin appendages, but you damage more of those. This is going to be white appearing because we are starting to damage those blood vessels, and so we're not getting that vasodilation, so it's going to be more white appearing. There may be areas that are not damaged, so you still see some erythema, you still have some blood vessels there, but we're damaging more of that dermis. It's going to be dry. You're going to see blisters still, but it's going to be dry, waxy, less elastic because we're damaging the stuff that makes the oil, right? And so if we take that out, we're going to start having more dry-looking skin. Reduce blanching because we're destroying more of those blood vessels. The thing with this one is that the pain is going to be decreased. It's going to be less painful because we destroyed more of those nerve endings. So we destroy those nerve endings, we're going to have less pain with that. Typically takes longer than 3 weeks to improve, but there will be scarring with this because, again, we destroyed most of those skin appendages, and so now we can't have that proliferation. So if we don't do certain things, if we don't treat this, then they may heal by secondary attention, which can cause that scarring, right? And then third-degree burns, these are full-thickness burns. These are where the epidermis and all the dermis are destroyed. We destroy the skin appendages, and it may go down to the sub-Q layer. This is going to look white and charged. So think about an egg. When you cook an egg, it's going to turn white. This is the same thing that's happening here. We got proteins in our skin that when we cook them, they start turning white. We're damaging blood vessels, so you may see these little black dots in the burn itself. These are just thrombosed blood vessels. It's going to be dry and leathery, again, because we don't have those skin appendages anymore to help moisturize that skin. These are not going to blanch because we destroyed those vessels in that dermal layer. The thing about these is that these are not painful, right? Because we went all the way down to the dermis, possibly the sub-Q, and so we destroyed all those nerve endings. Now, burns don't just burn in a straight line, right? They burn all over. So you may have varying levels of burns. So typically the periphery is going to be painful because it may not be as severe, but the actual third-degree area is not going to be painful. This says does not heal. If we don't treat them, they're going to heal by secondary attention and leave a lot of scarring. So if we don't treat them, they're going to heal by scarring. So what we typically do is we need to get these people to an actual burn center or some type of specialist who treats burns, because we can treat them with a skin graft, and I'll talk about that here in a second. But bottom line is third-degree burns, we're going to get to a very high level of care, that way they can treat these. So big thing is, so we talked about second degree, think blisters, right? Either partial or superficial partial or deep partial, they both have blisters. The first degree, these are very, think about a sunburn, right? You're not going to have blisters with that, it's going to be painful. When you go down to the third degree, we got white charged skin, we got no pain, so it's very kind of easy to break them apart when you can pull out kind of key characteristics from each one. Here's an example of kind of the layers of where the burns actually take place. The first degree epidermis, second degree just depends on how deep you're going into the dermis, and then that third degree goes all the way through. Here's what they can look like. So look at that full thickness burn, that third degree burn. You can see how it's white and charred. See those black dots? Those are thrombosed blood vessels. Some more pictures of burns. So what do you guys think that bottom left-hand corner is? You think that, what kind of burn do you think that is? Some type of secondary burn, right? Probably superficial, maybe. Looks like they had some type of blister that they ruptured there. But it's moist, got erythema. Skin grafts. Let's talk about skin grafts real quick. So with skin grafts, what they do is they take skin from the person who has the burn, skin that's not affected, and they take a layer of the epidermis and then a superficial layer of the dermis. And what they do is they run it through this special machine that meshes it, that puts holes in it, but also spreads it out, so it makes that surface area bigger. And then what they do is they put that skin graft on the actual burn, and they either suture it in place or they staple it in place. But they have that mesh, they have those holes in it. What do you guys think? What do you guys think they will grow together?
Let it stretch.
Surface area, yes. But what's going to be happening when you have these burns? You're going to have a lot of inflammation. And so these holes kind of help prevent that inflammation from, because if you didn't have it, what's going to happen is it's going to bubble up. So these holes kind of help with that drainage. But they also, so when you put down the skin graft, that skin graft is going to help that area heal. That way you're not healed by secondary tissues. That way you have less scarring with this. Because if you don't, then you worry about those contractures. And if they occur over a joint, and that contracture sets in, well then now you can't move that joint. And now this person has a disability. So you fix that, which, depending on where you're at, you may not be able to. All right, so thermal injuries. So we're talking about two things here. So trench foot and frostbite. Trench foot, this is due to non-freezing cold weather, so non-freezing, and in a wet environment. You need both to develop trench foot. What is considered freezing? What temperature? 0 Celsius, but what about Fahrenheit?
32.
31, okay, 32 I heard.
I like 32.
Close enough, close enough. So yeah, you need both. So if you have it, now what is cold? Cold is cold, right? But if you're not freezing here, that's the point. And you have to have that wet environment. Because what does water do to the skin? You ever take a shower, you got a shower, and maybe it's not cold in your house, but you feel cold, right? You need that towel. It helps dissipate heat. And so when we have water in a cold environment, we're going to be losing a lot of heat. Also, that water is going to damage the skin. It's going to cause maceration to the skin, which is going to cause other issues. What happens here is that you have from that cold, from that water, you're going to have vasoconstriction of those vessels that innervate that whatever tissue. Typically, it's the foot, right? When we have vasoconstriction, we start developing ischemia. Over time, if that ischemia persists for a long time, then we develop necrosis, which later on, once that reperfusion sets in, we may develop blisters, ulcers. If we have necrosis, that thing's going to die, so we may have to amputate potentially. Bottom line is we got to keep our feet dry when we're exposed to cold weather, but not freezing weather, because if not, you may develop trench foot. This was a big problem back in World War I. I was actually listening to a podcast the other day, and he was talking about kind of all things about World War I. This was one thing he talked about. And they also said that they used whale oil or whale fat to kind of help to coat the foot as well back then. So frostbite, now this is due to sub-freezing temperatures, so below freezing. So when you're exposed to below freezing temperatures, so less than 32, this is what you worry about. Same kind of process, you got vasoconstriction going on, and it's going to affect those things that are exposed. And really, you don't have a lot of blood flow to them to begin with. And think about the ears, the fingers, toes. When we're really cold, we're trying to bring that blood back into our core. So our body's going to say, hey, we don't need blood going there. We need blood going to our core. So we start having that vasoconstriction, which can lead to ischemia, which just leads to necrosis, right? You guys remember we talked about reperfusion injuries? Kind of, yeah. So that's the thing you worry about here is that whenever you have this vasoconstriction and then you reperfuse the area, you're starting to get all that inflammation and that oxidative stress, that damage that can happen. You start causing more damage to that area that was ischemic, and that could potentially lead to more damage, necrosis, and so potentially amputation. The bottom line is trench foot, non-freezing temperatures, but it's cold, and wetness versus frostbite, freezing. Okay. So infectious diseases. Common warts, so Bruchum vulgaris, this is due to HPV. Not the same kind of HPV we talk about cervical cancer. This is due to a different type, 2 and 4, some other ones as well. But these aren't STIs, so you're not going to get these by having intercourse with somebody. They don't turn into skin cancer. Essentially what happens here is that HPV virus, there's a break in the skin somewhere. It gets into the skin and it goes down to those, most bottom layer of those skin cells, the basal layer, and it starts to infect those cells. And it causes those cells to start proliferating. When those cells start proliferating, they start growing very, very fast. So as a result, you start seeing this growth on the skin. Typically, it's on the hands and the feet, things that you actually touch, other things, right? Hands, feet. When they start growing, they start making more keratinocytes, so they're going to be thicker. They're going to have hyperkeratotic lesions. They're going to be darker. They're going to be papules. You're having more of these skin cells proliferate because that HPV virus essentially is causing them to do that. They may be painful, especially if they're on weight-bearing areas. So if you have some type of mass under your foot and keep stepping on it, it might turn into pain. They may have black dots. Now these black dots, they're just thrombose capillaries. They're not, people call them seeds, I guess. They're not seeds, they're thrombose capillaries. And what happens here is that the dermis has those capillaries, right? And those capillaries sit right below that epidermis. And when these lesions develop, they can push on those capillaries, damage them, and cause them to bleed. So as a result, we can see them once they clot off, once they get thrombosed, we can see them under the skin. That's what those are. When we treat these, cryotherapy, other things we can do is there's some other type of treatments, but cryotherapy is going to be the mainstay, especially when you're out there in clinic. What we're trying to do is two things. We're trying to destroy those cells that are infected. Then we're also trying to cause an inflammatory reaction to call on our immune cells to come and say, hey, there's something going on here. Fight off whatever's going on here. So we're causing inflammation to bring our immune cells there to fight off this infection. Because HPV can do some things where it kind of hides from our immune system. But we're trying to kill those cells and then call on our immune system to try to fight off that infection. Recurrence is common. Yes, definitely. When people have warts, it's very common that they're going to have either development of a wart. Sometimes these things are super hard to treat. Like you treat them with cryo over and over and over, and these things persist. At that point, depending on how many they have and how long you've treated them, sometimes it's in dermatology. They can do all kinds of things with you guys. All right, herpes zoster shingle. So this is a reactivation of the varicella zoster virus. This is chickenpox virus. So what happens here is that you get chickenpox sometime in your life when you're a kid, and then that virus doesn't go away; it just goes dormant in one of the dorsal ganglia of your nerves, right? It can go anywhere in the nerve, and then later on, typically when you're older or when you're sick or when your immune system is suppressed, that our body can no longer contain it, so to speak, and so that virus comes back. And that virus is in the nerve, and so when it starts to come from that dorsal ganglion down into that nerve, down that nerve tract, it can start causing pain to that nerve. It can start causing damage to the skin where that nerve innervates. So it typically affects a dermatome, and normally it affects one dermatome. And the thing with dermatomes is, do they cross your center of your body? No, so these rashes are not going to cross. They're going to stay in one localized dermatome. Now, most of the time with these, you're going to have something called a prodrome, where typically what happens is that the patient will start having pain without any type of rash that develops. They may have redness later on, but the first kind of sign of this is they start having pain in a dermatomal region for no reason. So they're just like, hey, I'm having pain here, and you may evaluate them as I don't really see nothing. When you touch it, they're going to be sensitive to that area because that nerve is inflamed first. Once it starts to affect that skin, that's when we start seeing those skin changes. So typically, we're going to see vesicles that erupt first, and then it's going to progress to pustules as that inflammation starts to worsen. We start getting immune cells in there, and then eventually, once that starts to heal, we're going to have crusting. So it's a pattern. So we get vesicles, pustules, and then crusting. Once they have crusting, typically they're not infectious anymore. But why they have the vesicles, why they have the pustules, you do have to be careful because that stuff is infectious. And so if you are around anybody who has a low immune system or a pregnant woman, that can potentially pass on to them and cause a lot of issues. So we want to keep these covered while they're in that stage. Once they crust over, they're fine. They're not going to be infectious anymore, but it can take a little while. We typically treat these with antiviral medications, so acyclovir is a very common one we use. We can give steroids to calm down the inflammation. Depending on the level of pain, we'll give them pain medications. Typically, we'll give some type of like a medication for nerve pain, like gabapentin, things like that. Thing you worry about the most, though, with shingles is that if it starts to affect the trigeminal nerve, the ophthalmic branch of the trigeminal nerve, you gotta be super careful. You gotta take in, you guys took that test already? Optometry? No? Okay. So this is, you gotta be careful because that nerve that actually goes through our eye, right? And it could, if that virus gets into the cornea, it can start to damage the cells in the cornea, start to lead to scarring, which can potentially lead to blindness. And so when we start seeing any type of rash in that first part of that trigeminal nerve, you gotta be careful and you gotta get them over to ophthalmology quickly. Because if we don't treat them quickly and that cornea starts to become damaged, that can lead to permanent scarring. So when you see this, you can do, typically they'll do a fluorescein staining and you can see what are called dendritic lesions. This is just the virus replicating and causing these ulcers in that cornea. All right. So impetigo. So this is what I was talking about. We talked about those crusted lesions. So this is very common, either caused by staph or strep. Most commonly affects around the mouth of the nose because staph and strep love to live in that area, especially inside of our nose. And so you get these honey-crusted lesions. Again, you're going to get these pustules that form first, and once they've ruptured, you're going to get this crusting. This is very classic, and this is how they classically prescribe zygote honey-crusted lesions. Very common in childhood. This is very easy to treat, though. Typically, we'll give a topical antibiotic, and this patient will get better. Folliculitis, this is an infection of hair follicles, but this is limited to the epidermis, so it's not going deep into the dermis. It's just the hair follicle is infected, but it's still located in the epidermis. When it starts to go deeper, when it gets deeper into that hair follicle, then we develop something called a furuncle, also called a boil. It's a deeper infection that goes down to the dermis. It may look like a whitehead, but again, it's a deeper infection. It's going down deep. A carbuncle is just a furuncle with multiple of them, right? So you have multiple hair follicles that with a deep infection in the dermis. Typically affects the head or the neck because these are hairy areas, right? So it's very common to have this occur in those areas. Here's what that looks like. So folliculitis, again, stuck in the epidermis. Hair follicle still infected, but stuck in the epidermis versus the furuncle and the carbuncle, those are deeper. Our furuncle was just one, carbuncle was multiple. All right, so fungal infections, dermatophytes. So there's different kinds of dermatophytes out there, right? Doesn't really matter which one, but all the dermatophytes can potentially cause this. What happens here is that we have some type of dermatophyte infection, some type of fungal infection, and this dermatophyte likes and needs keratin, right? It uses keratin as food. And we have a lot of keratin in our skin, also have it in our hair and our nails. Whenever we get this infection, this dermatophyte uses that keratin to actually feed and grow. Now, little to no inflammation. These are, most of the time, just a little itchy. You're going to see some erythema from the actual infection, from that dermatophyte moving about. But this is not, sometimes people come in and just have the rash and no itching. That's typical. But they typically have, or they could have a little bit of itching. You worry about those secondary infections if you have excoriation, you start scratching that area because if it's itchy and you got dirty nails and you scratch it, then you got to worry about the infection. These are described, or these are, patients will come in and they say they have ringworm. Now it's not due to a worm, I think you guys know that from microbiology. It's due to a fungal infection. What happens here is that you got the infection, starts to eat the keratinocyte. Our body's trying to control it, trying to get rid of it, and it grows outwardly. And when it starts growing outwardly, that outer ring is the most active region. The inside is going to be central, or it's going to have central clearing. That's because our immune system is taking care of that infection, but the outside part it hasn't yet. But as it's growing, you're going to have an area of erythema with the central area where it looks normal. We treat these with antifungals. So typically, topical antifungals work really well to treat these. If you have tinea capitis, which is a scalp tinea infection, then you have to use oral antifungals because the topicals won't get deep into that shaft, and so you have to use orals. Now, depending on where the infection is at, is how we classify or how we describe it. So if it's on the body, your typical ringworm, it's called Tinea corporis. Tinea corporis is not a specific type of fungus. It's just, again, how we name it based on where it's at in the body. If it's in the groin, we call it Tinea cruis, also called jock itch. In the foot, Tinea pedis, that's athlete's foot. In the scalp, Tinea capitis. In the hand, Tinea manum, and then in the nail, Tinea inguinum, also called onychomycosis, but it just depends on where it's at, how you classify it. Idiopathic disorders, immune system. So eczema. Eczema is a broad category. It essentially means that there's skin inflammation. With eczema, the most common feature is that this patient's going to have itchy skin, right? It can look all kinds of ways. So it says plaque, papules, vesicles. I mean, they can look very, very different. So it's not very characteristic. You're not going to have one type of pattern. There's two types of eczema. We have exogenous eczema, which is that contact dermatitis. So that's that type 4 hypersensitivity reaction where we are exposed to something, maybe like nickel or something, and then we're exposed to it again, and then our immune system comes into play and starts starts to try to attack those cells, so we get this inflammation of the skin. Versus endogenous eczema, that's more of a immune system issue. That's that type 1 where you have that IgE production and activates those mast cells, and those mast cells cause inflammation. Atopic dermatitis is very common in children, babies. It does change based off, as they get older, it can change based off the way it looks and where it's located. But the big thing I want you to understand here is that exogenous, you got exogenous and endogenous causes, and really talking to that patient, getting that history is going to help you figure out what cause it is, okay? Because they can look very similar. One thing to be aware of is that you got to be careful based on the tone of the patient's skin, because in Caucasians, you get the classic, what we learn back, in textbooks of this erythema, this kind of dry-looking skin. But in darker skinned individuals, because that melanin is there, it may not look like the classic eczema, right? It's still eczema, but because we have melanin there, you can't see that erythema as well. And so we may just mistake that as dry skin. And so that's why you get that history from the patient and try to figure out when did it start and what are their symptoms, because it may appear differently. All right, seborrheic dermatitis. So this is pretty common. This is due to an overgrowth of a yeast called Malassezia. So a lot of people have this. Some people are just more sensitive to it. And it's a yeast, and what this yeast likes to do, or what it needs, it needs oil for it to grow. It needs oil to help it to grow. In the areas that we have a lot of oil, so our scalp, our eyebrows, our face, when this yeast starts to use those oils to grow, it starts to release fatty acids, which can cause inflammation to the skin. When it does that, when we have inflammation, that inflammation can actually cause those keratinocytes to proliferate. And when they do, they proliferate too quickly, and as a result, they start to fall off easy. They become flaky. So typically, you'll see this areas where you have a lot of oil, so nasolabial folds, eyebrows, behind the ears, upper chest, the scalp. You're going to see erythema, flaking, and itching. The patient's going to come out with itching. This is what patients, when they have dandruff, this is what they're describing to you. This is what this is. Different ways of treating this, but the most common way we treat this in clinic is we use something called ketoconazole shampoo. So it's an antifungal, and we use this antifungal, and it kind of helps bring down the levels of that yeast, which stops that inflammation and stops that flaking. You can also use steroids, but you got to be very careful. Short-term steroids are fine to use, but you got to be careful with long-term use because they can cause a lot of skin issues, especially if you're using it around the eyes, because steroids can sometimes increase the pressure in our eyes and cause glaucoma, so you got to be super careful. Now, typically with these, we're giving a low-potency steroid, not using it too long, so we don't have to worry about that, but still, especially if they're going to be using it for a while, we got to educate our patients and say, hey, be careful, use it around your eyes because it can cause increased pressures and glaucoma. All right, psoriasis. So this is a autoimmune disease, and essentially our immune system causes inflammation to the skin. And when that happens, it causes those keratinocytes to proliferate quickly. So normally, it takes about a month for those keratinocytes to go from the basal layer to the superficial layer to that corneal layer. With this, because that inflammation is causing those keratinocytes to proliferate rapidly, this is going from like, instead of a month, it's going from the bottom to the top within like 4 or 5 days. This rapid proliferation. As a result, you start to get this very thickened appearance of the skin because you have this increased layers, because it's rapidly proliferating, you have increased layers of these keratinocytes. So I told you inflammation, the body is causing inflammation to cause this, but we can also, when people have this, we can cause a flare in this by causing inflammation. So if we cause damage to the skin, if they hit themselves, if they some type of damage to the skin, that can kick off inflammation and cause a flare that causes it to get worse. Stress can also do it. Now, the way these typically affect your elbows and your knees. It can also affect your lower back, your chest as well. But when you think about this, very common sites are going to be your elbows and knees. It's going to be bilateral typically. So if you have any silvery scales at your elbows and your knees, you got to think maybe this could be some type of psoriatic issue. That's what that looks like. You can see that picture at the very right-hand corner. That's what normal looks like. And then with this condition, you have these proliferation of these keratinocytes. You got this very thick layer of epidermis. All right, so neoplasms. So seborrheic keratoses. So these things they look scary, they look bad, but they're benign. They're benign, they don't turn into cancer, they don't change into cancer. Most of the time, these are going to occur in your older folks. Typically, there's a genetic predisposition for this. Essentially, there's a proliferation of these epidermal cells. They make this characteristic, what's called stuck-on appearing lesion. And that's, you remember that word, stuck-on appearing, because that's how these things are described. And that when you document, that's how we typically describe it, stuck-on appearing whatever. They're not due to sun exposure. They're just from some type of genetic mutation that causes these tumors to develop up there benign. They're not going to turn into cancer. These are very easy to treat. We can either freeze them off by doing cryotherapy, or sometimes we can cut them off. But typically, if they're small enough, we freeze them off, they'll fall off. If they're bigger, we may have to cut them off. But again, they're not going to turn into cancer. But your patients are going to be scared. They're going to think it's cancer, but when you see them, you know what they look like. I'll show you a picture here in a second. Actinic keratoses. So these are, think of these as precancer. They look red. They're either red macular patches, and they're very rough appearing. So they're keratotic. They're scaly. They feel like sandpaper. So when you see them and you touch them, they're going to feel rough. They're going to look red. These are typically due to chronically sun-exposed skin. We consider them precancerous because they have the potential to turn into squamous cell carcinoma. And so oftentimes, we want to treat these before they turn into that. Now the risk is low, but the risk is there, and so we don't know. It's essentially dysplasia. Remember we talked about dysplasia? We don't know if it's going to turn into cancer, so we're going to treat them because if they do, now we have bigger issues. We can treat them with cryotherapy, so we can freeze them off. That cryotherapy is going to kill those cells essentially and improve that area. There are also other medications we can do. So there are certain types of medications like this 5-fluorouracil or 5-FU, where it essentially it causes damage to those cells that are replicating quickly while trying to spare the normal state. But the thing with this is you got to be careful. Not careful, you got to warn your patient. Because I'll show you here in a sec. If you don't tell your patient kind of what to expect, they're gonna not be happy. Right? So that's that 5-FU treatment, right? Look, typically because there's a lot of these actinic keratoses. Actinic keratoses. So we're using this. We can't just kind of spot treat this. We're using this cream because there's too many of them. But it's going to cause your patient to look like this. It's going to have very irritated looking skin. But we're only killing off those abnormal cells. The rest of the skin cells are going to be fine. It's these abnormal cells that we're killing, but the patient is not going to be able to go out for a while because they're going to look like that and be embarrassed. The seborrheic keratoses, those look scary. They look bad, but they're benign. They have this classic stuck-on appearance. So very benign disease that you can easily treat in your clinic. All right, let's take a 10-minute.
About an hour away from us, leave at 9, so we can get there.
My wallet.
I don't know how crazy it's gonna be. Like, 2 weekends left before we open. I think they start to meet. I assume it's Russia.
Shop back up. Every day like clockwork.
You never, right? These like I'm somewhere down, right? So I took it off. And I put me to place it. I took it off. Like this will remind me later that night. Let's replace it. And cook my headdress. And then we are. Using your fingers off. He's one of the best baseball players. I recommend if you're looking to buy it at a time and sell
Bro, tell me the dogs. That's the most
It's like sleeping. It's like
That was actually the first
I can't read anything.
You have like 2 jackets, 2 slates.
And I'm like wrapping a blanket.
Oh, can I borrow your blanket?
I'm not swear. CBC.
I thought I was, but last year, no. Yeah, we were taking tacos. It's just like
I'm not calling her by her name.
Wow, it doesn't even have audio on there. Just say, look, what a freaking favorites bunch? Favorites bunch? Wow. I swear to God. For me, once it gets closer. Thing is, I still don't have a fever. Still don't have my tonsils are still they don't have like any anxiety, so it's not like it's kind of even if it goes past 10 days, I doubt it'd be bacterial. You'll find out today.
I'll take a little peek.
Hey, I need a Z-pack. How about or what have I talked about?
Oh, I like my sauce.
Yeah, so joking.
Whatever sweater, jacket,
One minute.
Alright guys, let's get started. So we have another lecture to get through. Alright, so basal cell squamous cell carcinoma. These are the most common cancers you're going to see. Both of these, right? You're definitely going to see these in clinic. The problem with these, so I try to describe them in a way that's classic. The problem with these is that they can look very, very similar. So it can be hard to tell what they actually are, right? But classically, so basal cell, these are cancers of the epidermis. These are only in the epidermis. Classically, with basal cell, it's going to be you're going to see these on skin that's exposed to the sun. It's the sun that causes this damage to the DNA that causes this cancer. Same thing with squamous cells. It's the sun. So both of them are from the sun. There's a picture of two suns on here, right? The sun is what's causing this. So you get these mutations in the basal cells are those most deep layers of the skin. Remember from AP? You get this mutation, and when they start to develop this cancer, they have this characteristic curly, translucent papule, so it looks shiny. They're going to have rolled edges, and I'll show you what I mean here in a second. And they're going to have telangiectasias, which are small blood vessels inside of the actual cancer. If that cancer sits for a long time, it may actually ulcerate in the middle, so you'll have a central depression. So that's what classically this looks like. The good thing about basal cell is that it doesn't normally metastasize. It has to be there for like a long time before it does. The way we treat this is that we got to cut them out. We need to cut this out. It says full depth excision. What that means is that, so I told you that these cancers are in the epidermis. Because there's the potential of it going down to the dermis and metastasizing, we cut the whole thing out. We cut the epidermis and the dermis out. You can definitely do these in clinic if you feel comfortable. If not, you can always send them to dermatology. But very, very common. Squamous cell, again, caused by sun, just like the basal cell, right? You're going to see these on sun-exposed areas. Now these classically look hyperkeratotic, they look thick, they look scaly. So when you touch this thing, it's going to feel scaly. So it looks very similar to actinic keratoses. The difference is that you're going to have recurrent bleeding with these, especially if it starts to get into that dermis, because these actually can have a greater risk of metastasizing. They may ulcerate as well. They may crust. Same kind of treatment though. We're going to cut that whole thing out. We're not just cutting out the epidermis, we're cutting out the dermis as well. I had a dude one time, he came in for a physical when I was first at my first phase. He came in for a physical, and I'm looking at him. He came in just to kind of, get his blood pressure checked, get his labs and all that stuff, right? And he's talking to me, and I see like this lesion on his head. It's like, looks like a sore. And it's big. And I'm like, hey, sir, how long have you had that how long have you had that lesion on your head? Oh, about a year. Oh, anybody ever look at it? No? Okay. That's not normal. It's not normal to have a sore for a year, right? And so I said, let's go ahead and biopsy because it might be cancer. If we biopsied it, it was squamous cell, and then we sent him off to dermatology and cut it out. So he had it for a year and didn't metastasize, right? So, but yeah, he didn't even come in for that. So that's why you gotta look at your patient too. They may come in for one issue, but then also while you're talking, I'll kind of look them up and down and just make sure you don't catch anything because you might miss that.
So I have a question. Do you ever shave them off? Because I was always taught to shave them, like the superficial, and then they can cut it so they can make sure they get the margin.
Yeah, so if they're small enough, I'll shave them off. If they're too big, if they're bigger, then I'll typically send them to dermatology for that situation. Yeah, definitely you can do a shave biopsy.
And so with the actinic keratosis, is that what's progressing to the cell?
Squamous cell.
Solely.
Because with the squamous cell, the problem is higher in the epidermis. Typically, it's that stromal spinosum, that layer above the basal layer. So it's where that cancer starts to develop. So basal cell is deeper, starts at the basal layer. Squamous cell starts a little bit higher. But actinic keratoses can transform to squamous cell, not basal cell. Okay. So here's kind of what that looks like, right? So again, what you're going to see up top is just, I'll show you what these actually look like. You can see this lesion up top, but down below is where the problem is. The basal cell starts at that basal layer, the squamous cell starts a little bit higher. Okay. Warning signs of skin cancer. So yeah, like I told you guys, if somebody has some type of skin lesion that's persisting and looks like a sore, that's not normal. It could bleed easily. These things can bleed, especially if they're longer, so that's not normal. If they have an irregular shape with unclear margins, yeah, cancer starts to spread out, so it's not going to be a nice little, well, let me take that back. Basal cell can look that way, but it has other features. Sun growth in sun-exposed areas, or new growth in sun-exposed areas, so it's that sun, again, it's that sun that's increasing that risk. And it's surrounded by atrophic and keratotic skin. That's typically from sun damage. So if you have sun damage, it's going to cause changes to your skin. That skin's going to look thinner. That's what that atrophic means. And then keratotic is just that increased amount of keratinocytes. It's going to look scaly. So anything like that going on, you got to think potential skin cancer, basal cell, squamous cell. So here's what they classically look like. So basal cell, you can see how it's dome shaped. You can see in the center it's starting to have that central depression. You can see those telangiectasia, those blood vessels in the actual cancer. Versus squamous cell, that kind of looks like actinic keratosis, right? I mean, it looks scaly. So it can be sometimes hard to differentiate between the two. So if you think, even if you think it's cancer, just go to dermatology. I mean, that's the safest thing to do. If you feel comfortable, then you can cut out yourself, which is, and derm will talk to you more about like when to actually do that. But they don't always look this way. They can look very, very similar to each other. I know these look different, but in real life they can look very similar. All right, lentigos. So these are caused by also sun, right? These are benign lesions. They don't turn into cancer. They don't turn into anything bad. They're sharply demarcated. Again, you can see where that lesion starts and stops. It doesn't fade into the skin. It doesn't taper to the skin. These are typically due to melanocytes that proliferate. So essentially think about it this way. You have melanocytes in your skin. Over time, if you're constantly exposed to the sun, they're going to undergo hyperplasia. You're going to make more of them. But the thing with these melanocytes, when they make more of themselves, that they don't change with sun exposure. They lose that feature to get darker when you're exposed to the sun. So they're just melanocytes that you have increased number, but they don't get darker in the sun, which is typically what happens with melanocytes. They're different than freckles. Freckles are just melanocytes that make more melanin, and they get darker in the sun. Freckles are not. You're not making more melanocytes with freckles. They just make more melanin. Nothing you really got to do for these guys except just reassure them, right? Now melanoma. This is the one you guys got to be on the lookout for. This thing will kill a patient. It typically is on sun-exposed areas, but there's also a genetic cause for these, where people who have a family history of melanoma can actually develop melanoma. So sun definitely can do it. But genetics also play a big role in this. That's why it can occur anywhere. You can have them behind the eye. Typically we think about skin, right? You can have them in your toe. You can have them in your groin. These things can pop up, and when they pop up, you got to jump on this right away. It's something you just can't sit on. If you have any type of new or changing macule or the A, B, C, D, E signs, I want you guys to commit A, B, C, D to memory because it's very important, not just for pathology, but for life. And I'll show you what that means here in a second. Because this thing has a very, very high risk of metastasizing. And once it does, it's hard to treat, and most patients will die once it does metastasize. Do not biopsy this in your clinic. Don't even think about it. Even if you feel great about being, you feel like you can do these really well, don't do it because they actually need to see how far this thing goes down for them to accurately stage it. If you just take out a chunk of it and you don't get all the way deep down over it and you don't get the margins, you're going to jack up the way that the dermatologist can actually stage this cancer, which is going to impact the treatment of this. The best thing you can do is get on the phone, say, hey, doc, dermatologist, I got this patient I think has melanoma, this is what's going on. How soon can we get them into your clinic? And let them tell you how soon. Don't try to even play with these. Don't try to mess with them. 30% can arise from pre-existing moles, for sure. 70% arise from de novo lesions. So I told you guys that everybody has the same amount of melanocytes in their body, right? Some of them don't make melanin, but they're still there. And so when this thing kicks off, you may have a new mole that's changing that you didn't have before because you still have melanocytes there. You just don't make melanin like the rest of them, right? So that's how these things kind of come about out of nowhere. All right. So again, this is very, very important to know. The ABCDEs of melanoma. This is what you're going to tell your patients too after they come in for some type of skin exam. You're going to talk about this with them so they're aware as well. So if a lesion is asymmetrical, that is not normal. Most of the time, moles should be symmetrical. Most of the time they should, right? Unless you're born with it, it's always been that way. Maybe that's different. But anybody who has a mole typically has a symmetrical appearing mole. It's going to look the same. The borders, if they're irregular. So if you have a lesion that has irregular margins, so it doesn't look nice and you can't see where it starts and stops, kind of fades in the skin, or looks ragged or notched, that's not normal. You need to get them over to the dermatologist. The color, so a mole should be the same color throughout its lifespan. If the mole is changing in color, it's changing from, and it starts getting these other new colors like red or blue, which can happen, that's not normal. Diameter, so typically moles, unless you're born with them, typically they're smaller than a pencil eraser, so less than 6 millimeters. If that thing is getting bigger, that's not normal. And the biggest thing patients should look out for is the evolution, because melanomas change relatively quickly, depending on the type of melanoma. If the patient notices any change in that mole, if it's evolving, again, that's a concern that this is a melanoma. We need to get them over to somebody who can actually get rid of this thing. So here's some examples of benign versus malignant. So freckles, lentigo, and the nevus, those are all normal. The melanomas, there's different kinds of melanomas. In dermatology, we'll get into those with you. But anything that looks irregular like this, you need to get them over to the dermatologist. And you got to remember those ABCDs, because you got to educate the patient about what to look out for. All right, questions about that? So bones and joints. You guys are going to get into a lot of information with bones and joints when you get to next semester. A lot. We actually do very, very well on the hands. This is like the best thing we do well on as far as iPad goes when it comes to hands. So you guys, you're going to see a lot of this. Quick anatomy review. So this is just talking about long bones here. There's other bones. I know you guys have learned about them in AP. I just want to kind of orient you to a long bone. This is the one we're talking about the most here. So you got the epiphysis. Those are the proximal. You got the proximal and distal epiphysis. Those are the ends of the bones, right? So that's where the cartilage is. That's what connects to other joints. In the middle, you got the diaphysis. That's that long part. And in between the epiphysis and diaphysis, you have the metaphysis. In a child, you have epiphyseal plates. That's where that bone elongation actually occurs. Okay. Let's see. That's good for now. So congenital abnormalities. So chondroplasia. This is dwarfism. These are. I don't think they use that term anymore, but that's what it is. So the problem here is that these people are born with a genetic abnormality that stops their chondrocytes from proliferating. So at the epiphyseal plates, you have chondrocytes, and they proliferate. And as they proliferate, they push that epiphyseal plate upwards, which causes elongation. As those chondrocytes start to mature, they start to lay down their own little matrix, which then osteoblasts, which build bone, come down and calcify, right? If we stop this proliferation, then they're not going to grow, right? And if we stop this proliferation, they're not going to mature. So they're not laying down that groundwork for those osteoblasts to come in and make bone. So as a result, these kids or these folks are going to have very, very short arms and legs and other things too. That's called endochondral ossification. There's a different type of way bone is made called endomembranous ossification, and those bones that are made that way are not affected. So that's why they can have normal features in certain bones and then abnormal features in other bones. Big thing I want you to be aware of is that that's what's going on at the epiphyseal plate. So they have shortened legs and arms, but the rest, some other bones like the clavicle, the mandible, the upper cranium, those are all those all make bone differently, or they all grow differently. So that's why they're not affected. Osteogenesis imperfecta. You guys, you ever watched that movie Glass? Mr. Glass? Yeah. This is what this dude had. So the problem here is that there's a genetic disorder where we don't make enough type 1 collagen. And type 1 collagen is what makes the bone matrix. It's what makes the scaffolding for then those osteoblasts to come in and put that calcium, that phosphate in to actually make bone. So without that type 1 collagen, or if you're deficient in that, you don't have that framework for then that calcium and that phosphate to actually to lay down correctly. So without that framework, those bones are weak. So I have this example here. So think about like when they're pouring concrete. They pour concrete. Before they pour the concrete, they put steel rebar. That reinforces, that strengthens that concrete. That when we actually put down the cement, it's harder. It's more sturdy. So think about it this way: they don't have that steel rebar, or they have very little amount of it. So these bones are weaker, not because they don't have enough calcium and phosphate, because they don't have enough of that framework. These folks, they develop they can have bone fractures that develop very, very easily. So a lot of times we'll think they have this, that maybe this type of child abuse going on. They just don't have one fracture, they have multiple fractures. And so you bring in a kid who has this, and they got like, fracture of the clavicle, an old fracture of the rib, right? We're gonna think probably abuse. So it's very, very commonly associated with, we think, when we see this, we think that it's tough child abuse, but it's not. It's just a genetic defect. They may have blue sclera, or they should have blue sclera, because collagen is not only in the bones, it's also in the sclera. It's also in our joints. When we have decreased collagen, that you can see through, it's more translucent, so we can see the underlying uvea through that. So that uvea, you can see that blueness of it. And then brittle teeth, hearing loss. Again, we got collagen in our teeth. We got collagen in our small bones of our ears, so we can have other issues besides just the bone breakage. So here's an example of chondroplasia versus osteogenesis imperfecta. You can see on that X-ray. I mean, look, you got a clavicular fracture. You got multiple rib fractures, some at varying levels of healing. So that's how you easily can think this is child abuse. It's not. All right, infectious diseases. So osteomyelitis. So this is a bacterial infection of the bone. So for adults, more commonly, we're going to associate this with open fractures, surgeries on the bones, diabetics, chronic ulcers that can actually start to go deeper into the tissue and then eventually go into the bone. I think that makes sense, right? If you expose a bone to bacteria from these kinds of situations, then there's a chance that they can develop into infection. We want to treat these. Most of the time when we have osteomyelitis, we're going to get them over to orthopedics. We don't know where she's going to go, so we're going to get them over to ortho. And then if it's a fracture, they're going to try to clean out that area and close it within 6 hours to try to reduce that risk of infection. Children, I want you guys to remember children. Children are more susceptible to developing blood infections, right? So if a child, because they have a lower immune system, if they have like some type of pneumonia or something like that, because they're a lower immune system, they're at greater risk of developing a blood infection. So if a child has pneumonia, so pneumococcal pneumonia, right? If that gets into the blood and starts spreading through the blood, there's a chance that it can go into the bone. And most of the time when this happens, it goes to the metaphysis, because the metaphysis has a lot of blood there, and that blood is very slow. So when it gets there, it potentially can then go up to the epiphyseal plate and start to destroy that epiphyseal plate, which can cause bone shortening, bone deformities. That's the thing obviously we care about the bone infection, but if we don't treat this in time, we cause issues elsewhere as far as growth goes. So very, very important that you guys know that. Treat this with antibiotics for sure. It's going to take a long time, so we're going to give them a lot of it. We're going to give them antibiotics for an extended period of time. And then advanced cases, they may require some clean out for sure. But again, like I told you guys, practically you're going to get them, in real life, you're going to get them over to ortho and they'll take care of this for you. But you got to be able to identify it. Metabolic disorders. So, osteopenia and osteomalacia. So what's the difference, right? So osteopenia, this is due to thin bones. You have thin bones here. Now, you have normal mineralization, meaning you have normal collagen, and you have normal calcium and phosphate. That's what makes bone, right? Over time, we can start to break down that matrix. So we have thinner bones, but we still have the right amount of ratio. So we have a normal amount of collagen, or we have a normal ratio of collagen to calcium and phosphate, we just have less of it. When we have less of it, we have less bone, right? So we have thinner bones. Osteomalacia, this is due to a problem with actually trying to mineralize the bone. So we don't, it's a quality problem. We are not putting enough calcium and phosphate into the bone. So we essentially have more collagen than calcium and phosphate. Okay? Osteopenia and osteoporosis, this is essentially the same thing. Osteoporosis is just a worsening level of it. So we have a lot of decreased bone mass. Same amount of ratio, we still have the same amount of collagen, calcium, and phosphate. We just have less of it, so we have less bone mass. We have less bone density. Osteomalacia and rickets. So osteomalacia and rickets, they're the same thing. They're the same exact thing. We classify them based on age of the kid, though, or the age of the person. Because whenever it happens in an adult, we call it osteomalacia because the epiphyseal plates have closed. And I'll show you why this is a problem with kids. Rickets, this is because the epiphyseal plates are still open, but it's the same thing. It depends on age, and really those epiphyseal plates are open or closed. Osteoporosis. So, the problem here is that we have osteoclasts, and you guys know that they break down bones. We have osteoclasts. They outpace the activity of the osteoblasts. So over time, if those osteoclasts are doing more than the osteoblasts, they're breaking down bone, then we're going to have less bone mass. We're going to have thinner bones. This is very common in females who have a small, thin body frame, because you got to think. Women have naturally, they have a decreased bone mass, than men. So if you have this issue, you already don't have a lot of bone mass as it is, any bone mass that you lose is gonna put you at risk of developing this. Women, so as we get older, this naturally happens in both men and women. Women though, they make estrogen, right? Estrogen's job is to do a lot of things, but one of its jobs is to induce apoptosis of the osteoclasts. So when women go through menopause and they lose that estrogen, they are no longer causing those osteoclasts to undergo apoptosis. So now you have more osteoclasts, which are breaking down bone. This is why estrogen in women. This is why this affects women more. Sedentary lifestyle. So when you work out, when you put stress on the bones, it can actually make those osteoblasts more active to make that bone more stronger. So if you are just sitting there, PA school, not working out, potentially you're going to decrease that bone mass because you're not stimulating those osteoblasts to reinforce that bone and make it stronger. Poor diet, so low calcium and vitamin D. So think about it this way. If you have low calcium, you have low vitamin D, where is your body going to get that calcium from? From your bone. And it's not just taking calcium with it because it's breaking down the actual bone. So it's breaking down the collagen, it's breaking down the calcium, it's pulling phosphate. So again, we're pulling that calcium and phosphate, breaking down the collagen, so we're pulling that mass from the bone. If you have low calcium vitamin D, this can make this a lot worse. Very commonly occurs in the hip, especially the femoral neck. So that area is if it breaks, there's blood supply there, but if we break that hip, we can damage those blood vessels, which can cause a problem with healing. If we rupture, we cut those blood vessels, it's not going to heal correctly because we need blood for tissue to heal. And that's a very common area, and that's actually where we check for this whenever we do the DEXA scan, which we'll talk about here in a second, to kind of see how much bone density is in that hip. Because if this happens, you got to think, if somebody has a hip fracture, they're going to be down. They're going to be in bed. Typically, these folks are older, and so when you're in bed, laying there, what you're at risk for if you're just kind of laying there and not moving around. DVT, right? And so, I guess that. DVT, pneumonia potentially. If they're just kind of laying there, they're at increased risk of having increased mortality with that. Vertebral fractures. So kyphosis, also called a Dowager's hump. You guys know what a Dowager is? No? You guys watch Downton Abbey? No? Okay. When you graduate from PA school, I recommend it. So a dowager, all that, it's an old term that they used back in the day for typically widows who their husbands died and then they inherited the property. So that's what a dowager is. There's a lady on Downton Abbey who's a dowager. And so this older lady, right? This dowager's hump is what they called it. Essentially, it's a hunchback from a vertebral fracture. If the vertebrae is fractured, if the body of the vertebrae is fractured, it's going to compress, right? If it happens up somewhere high, you get kyphosis or that hunchback. And so they have this compressed vertebral body. now they're bent over like that because of that fracture. DEXA scan is how we normally find these. So it's a special type of x-ray, kind of tells us how much bone density is in the actual bone itself. And then based on this level of severity depends on what we do for it. The way we treat this is with bisphosphonates. Bisphosphonates, their job is to essentially induce osteoclast apoptosis, so to decrease the number. So by doing that, we can stop this from breaking down that bone. We can also give estrogen, especially if they're postmenopausal. Exercise is very important all throughout a woman's life, and so we want to make sure that we're educating our women to make sure they're exercising both young and old, because the more bone mass we can put on them, the greater we can reduce the risk of developing this later on. Proper diet, calcium, vitamin D. Again, we don't want the body stealing the calcium, from the bones, and so we make sure that they're eating correctly, and they'll be fine. Yeah.
Sir, so if you're at the hospital, would you implement those same treatments to prevent it from progressing?
Not the bisphosphonate. You would still do the calcium, vitamin D, exercise, and then watch your patient. But once they have osteoporosis, that's when we'll start doing the bisphosphonates. When you do a DEXA scan, it's going to give you a score. Did you talk about this in radiology? No? There's a score that it gives you. And then there's recommendations based off that scoring of how to treat this patient. There are guidelines out there, but don't worry about that now. But definitely, it's something that you're going to care about whenever you get into practice.
Like my mom, she called me last night. Like, can we talk really briefly?
Yeah.
All right, it's probably something serious. So she's 66. She just had a DEXA scan. Everything was less than 2.5.
Yeah.
So she was like, "Hey, they're saying I have osteopenia. Like, what is that?" And so I was like, "Hey, like, probably just decrease bone density.
Yeah.
Everything at this time. And probably like poor diet, and you need more like vitamin D and calcium. You're like postmenopausal."
Yeah.
But she was like, "How do I fix that? Outside of vitamins, I couldn't tell."
Yeah, I mean, hopefully, has she seen her doctor yet to go over the results?
She's about to do a follow-up.
Okay. They'll tell her, but yeah, we want to prevent it from getting that bad. So exactly, exercise, diet. If she's postmenopausal, maybe estrogen, but there's a risk with that. That can help mitigate that. Yeah. So here's what this can look like. So there's that Dowager hump. You can see that vertebral body is fractured, so it slants inward, and so as a result, you start having that kyphosis that can develop. The femoral hip, so that place likes to break, and so if it breaks, you're going to potentially have long-term complications. Because the way they treat this, they either do pinning or potentially do a hip replacement. But you got to think this patient's old. You really want to do that on an older patient who already has osteoporosis, who probably doesn't have, maybe has other health concerns. And so you got to. That's where that risk comes into play. All right, rickets. So rickets. So this is osteomalacia, but in children. So this is softening of the bones. This is due to inadequate nutrition. So inadequate vitamin D, calcium, phosphate. What happens here is that, if we're not having enough vitamin D, calcium, phosphate, if we don't have vitamin D, we're not going to absorb calcium and phosphate as it is. If we're not having calcium, phosphate in our diet, well then definitely we're not going to absorb it. So our body's going to start stealing that calcium and that phosphate from our bones. And as it does that, it causes those bones to become weaker. Now, the problem here is that because those epiphyseal plates are still open, those chondrocytes are still proliferating, right? They're still growing and they're still pushing that growth, but we don't have enough of those products to actually cause that ossification of the bone. So as a result, because we have this epiphyseal plate that's not ossifying, that we're not getting hard we're not making into bone, those epiphyseal plates, that stuff is softness. As this kid is growing bigger, that weight is going to cause deformities at those epiphyseal plates, which is going to cause these kids to have bow legs, right, or genu-varum. They can also have knock knees, so genu-valgum. They can also have that too. So bow legs is associated with this, but so can knock knees, right? They can have sternal projections. So what is it called? You guys ever heard of it's called pigeon chest, but I forget the pectus carinatus. Yeah. So This can happen with these guys too, where they have this, because you have cartilage here as well, it can cause this to keep growing, kind of ossifying, so their chest can form like a kind of like a triangle shape, right? And then other things, muscle weakness, bone fractures, things that make sense. So how do we treat this? Calcium, vitamin D. Essentially, we want to give them that nutrition. We want to make sure they're not stealing it from their bone. If it's really bad, if their bow legs are really bad, we'll get them over to Ortho. But most of the time, if we can correct it early, then this will correct itself. This is not. I guess this is this can happen in the States. It depends on kind of person and kind of how they grow up. All right, osteitis deformans, Paget's disease. So this is pretty rare. What happens here is that there's some type of genetic issue with these folks where they have this localized bone remodeling. So they have this localized area where these osteoclasts start breaking down these bones. And they start breaking down quickly. Again, it's localized. When they start breaking down this bone, they start to cause weakening of the bone, right? Then what's going to happen is it's going to transition. Then the osteoblasts are going to come into play, and the osteoclasts are going to calm down. They're going to stop building. They're going to stop pulling from that bone, and the osteoblasts are going to come in, and they're going to start trying to lay down that bone matrix and that calcium and that phosphate to kind of patch up the area where those osteoclasts pulled that bone from. But what the problem here is that these osteoblasts, they don't do it in the normal way. They just kind of go here and there, and it's a haphazard way. They're not doing it in a linear fashion. So what you get are these areas of weak bone, these areas of increased, what's called sclerotic bone, where you have increased calcium phosphate being put down. So because you have this weakened area, and then these spots where these osteoblasts are trying to increase that bone put down, you're going to have weakness of that bone. You don't have that normal kind of linear shape of the bone anymore. Because you have these patches of, what are called lytic lesions, so decreased bone, and these patches of increased bone. So it's not nice and normal, just bone. It's patches of decreased bone and increased bone. It's going to affect pretty much any limb, pelvis, lumbar spine, femur, but again, it's localized. It's not a full body thing. They may have one bow leg, so if it affects the tibia, again, if we start pulling from that bone, and then we start replacing it with more bone, but we're not doing it in a linear fashion, it's going to cause that tibia to weaken, and as it does, it's going to start to bend and cause this kind of bow-legged appearance. Lytic lesions, so when you shoot an x-ray, you're going to see what are called lytic lesions. So this is just from that bone being taken down, that bone being broken down, and then you're going to have patches of areas where those osteoblasts are trying to put more bone into it. So it looks like a cotton wool, looks like cotton wool. So it doesn't look nice and linear. It kind of looks like a cloud, right? We treat this with the bisphosphonates. Again, we want to stop those osteoclasts from breaking down that bone. If we can do that, then we can correct this, or at least help it. Traumatic injuries. You guys covered fractures in radiology, right? So make this an FYI. There's different kinds of fractures. There are some that are mostly associated with kids, like Torres and 3-6. You guys covered it in FYI. Don't make this an FYI slide. Don't make this one. So the way when you have a fracture, there's a stepwise approach to how they heal. And I would definitely know the sequence of events, right? The sequence is important. So when you have a fracture, what happens? You have bleeding. When you have bleeding, what happens? You have hematoma that develops in that fracture site. That's going to happen for the first couple of days where you have this bleeding going on and immune cells are coming in. You're also calling in chondroblasts, you have fibroblasts, you have osteoblasts. They're all in that area. They're coming in, right? They're getting ready to try to repair this. But first we got to stop this bleed, or we got to stop this bleed. And so we're going to start clotting that area, try to stop that, bring these immune cells for eventually for the next stage, it's fibrocartilage stage. Fibrocartilage here, so it's after about a week, the body starts to try to correct this. And it's going to lay down this fibrocartilage mesh to bring those bones together. But that mesh is soft. And so when you shoot an x-ray, you're not going to see it because it's not calcified. So it's going to look like this hole or this divot or this open space. But you have this fibrocartilage area there that's bringing those bones together, but it's still weak. So if this thing moves around, you're gonna restart that process. Osteoclasts are removing dead bone. Those fibroblasts are laying on that collagen to make that fibrocartilage mesh. And osteoblasts are coming in and they're starting to make their own type of matrix, but it's not hard yet. And then after about, and I make this point here too because sometimes when you have a patient who has a fracture, it can be very, very hard to tell, depending on the level of severity of how that fracture is. And so if you shoot an X-ray right off the bat, it may not look fractured or it maybe look fractured. And then if you wait a couple of weeks, once you start to develop this bony callus, then you can actually see the fracture. So it's very useful. If it's questionable if they have a fracture, to kind of wait a couple of weeks, and then once this bony callus starts to develop, then you can tell, okay, yeah, this person has a fracture. Anyway, bony callus. So after about 2 to 4 weeks, those osteoblasts are going to start building new bone. Now this new bone is new bone. It's not the kind of bone that we want, but it's good enough to kind of make things stable. Osteoclasts are going to come in. They're going to start trying to shape that bone into the eventual model that we want. And after about 8 weeks, that remodeling process begins where those osteoblasts start laying down more mature bone, and those osteoclasts are coming in and they're starting to break down some of that old bone in order for this to actually develop into a stable fracture or a stable stable enough for healing. But we need movement for this. So I told you guys with osteoporosis, movement helps build that bone, right? Putting stress on that bone helps make that bone stronger. So this happens after movement. Once you start getting that patient back on their feet, now that fracture is stable for them to start doing things slowly and steadily. Things that promote healing of fractures, well, alignment, I think that makes sense. If that fracture is not aligned, you're at risk for that thing trying to heal. But if it heals and it's not in alignment, you're going to get something called malunion. So you may have an angle deformity of that fracture depending on how displaced it is. If you don't immobilize it, well, then you're going to restart that process. You've got to keep bones still, that way this process keeps happening. Good blood supply, I think that makes sense, and good diet. So vitamin C is important for collagen, and then all the rest is for bone development. So again, I know this is an FYI slide, but I would definitely know the sequence of this because it's important to know. Joint diseases, osteoarthritis, so degenerative joint disease, very, very common, very, very common thing you're going to see. It mostly affects the weight-bearing joints, the knees, hips, vertebrae. It can also affect other joints, so you can get it in your elbow, you can get it anywhere where you have a joint, but most commonly it's going to affect those weight-bearing joints. We put a lot of force on those whenever we live our life. Fingers are also affected, especially people who use their fingers a lot, like people who type a lot, like you guys are going to do when you get practice. So that repetitive motion, repetitive force on those joints can start to break down that cartilage that covers that joint. And that cartilage's job is to protect the bone and absorb shock. With time and as we get older and as we live life, that cartilage can start to break down. When that cartilage breaks down, the undersurface of that, where the bone is, you start to see it, right? But that bone needs to be covered by cartilage. If you don't have that cartilage protecting it, now you're exposing that bone to that force that normally that cartilage would absorb it. What can happen is that you can start to develop these bone cysts, which are these kind of microfractures in the bone, and synovial fluid is in joints, and so that synovial fluid can move into that microfracture and cause these cysts in the bone. You can also develop osteophytes, and osteophytes, essentially it's just your body's way of trying to distribute the stress of that joint. So by increasing the surface area, by putting these extra bone around the margins of the joint, you can transmit the force from the joint to the greater surface areas, which helps bring down the pressure of that joint. These osteophytes are really trying to help, but they cause other problems as well. These patients are going to be stiff. Initially, when they get up, start moving around, they're going to be stiff and painful. And then about 20 minutes later, that pain is going to reduce. That's because synovial fluid's job is to help lubricate the joint. And so when we're sitting at rest, that synovial fluid kind of it settles. And when we start moving that joint around, it's going to cause that synovial fluid to start moving around again. So it's going to lubricate that joint. So the patients are initially stiff in the beginning. As they move around, it's going to feel better. Tender and swollen, for sure, because you got inflammation going on, but The thing with this is that inflammation is a very, very mild inflammation. So when you touch that joint, it's not going to feel hot, it's not going to feel warm, it's not going to feel like a septic joint or like an infection. Crepitus, because you don't have that cartilage anymore, bone is rubbing on bone, and so you're going to feel that crepitus when these patients with that joint. The finger nodules, so there are things called Bouchard's nodules and Hebrides nodules. Bouchard's are at the PIP, and the Hebrides are at the DIP, so PIP, DIP. These are very common in people who have arthritis of the hand. These are just osteophytes that develop. Shoot an x-ray, you're going to see joint space narrowing. So if you're losing that cartilage, that joint space is not going to have that nice open spot anymore. Those osteophytes. You want to remain active because remaining active is going to help increase that synovial fluid. You can give NSAIDs for pain. And then if it's really bad, you can send it to the ortho and they can do all kinds of things. This little yellow box here, patient may have they have prominent X-ray findings with a little pain. That's true. I had a Marine one time. His knees were jacked. Like there's nothing there. But he was fine. I was like, okay. But you wanted me to shoot X-ray with me because he was fine. Anyways, here's what that can look like. So you can see that joint space narrowing of that knee. So normally you have a nice open space from that cartilage. These guys who have arthritis, they're going to have that narrow joint space. And there are examples of the Hebrides and Bouchard's nodules. Rheumatoid arthritis, so this is an autoimmune disease. Essentially what happens here is that the body starts to attack the joints, and it starts to cause erosion of that cartilage and the bone. What's not in here, which I think helps kind of understand this, is that when you have chronic inflammation, you have fibroblasts that develop, right? Those fibroblasts lay down a fibrous collagen. What can happen is that after a while, that cartilage or those fibroblasts, that fibrous material start to ossify. When it ossifies, when it gets hard, it's going to cause fusion of that joint, so that joint can't move anymore. It's not going to be mobile. That part is missing here. It does start slow, for sure. It's not something that just kind of happens out of the way. Another feature of this is that it typically happens bilaterally, and it typically affects the small joints first. So the wrists, the MCPs, PIPs, those are typically the most commonly involved areas. They can affect the ankles too. But patients will come in and they'll say, hey, I'm having a lot of wrist pain, and then get their history and then find this. They may have a Z deformity, and I'll show you what that looks like here. Essentially, the wrists are going to have an ulnar deviation, or the fingers are going to have an ulnar deviation, the wrist will have a radial deviation. They kind of look like that. Doesn't really affect the large joints, that's true, but it can over time, as long as if you don't treat this, then it can start to affect the large joints. There are labs you can do. The problem is that they're not that good. So rheumatoid factor is one type of lab you can do. There are other ones, but this is the most common one that we do. If it is positive, it doesn't really tell you that this is still rheumatoid arthritis. You've got to get the history and do other things to really diagnose this. And then your x-ray will show erosions from that inflammation. We give NSAIDs for pain. There are other medications we can give, like methotrexate, just to calm down that immune system. So we give NSAIDs, but we also treat it with medication that kind of lower that immune system. Here's that Z deformity. So this is typically people who have like chronic rheumatoid arthritis. It's not somebody who just develops it. It's going to take time for this to happen. All right, gout. Gout. So here you have an increased amount of uric acid production. Uric acid, we normally there are these things called purines. We get these from our diet. Purines are also important for just DNA metabolism. We need purines for our DNA, but we get our purines from our diet. When we have too much purines, they're broken down, they're metabolized into uric acid. When we have too much uric acid, they start to crystallize and make these uric acid crystals, which cause a lot of issues in our joints. So they can happen from if we have too much purine coming into our body, whether by eating it or drinking alcohol or eating sugar, then we can make more uric acid. If we're under-excreting it, so if we're dehydrated or if we're taking medications that make us reabsorb uric acid, then we can have it that way as well. But the bottom line is that we have an increased level of uric acid in our blood. Most commonly, it's going to affect the toes. It's called podagra. When we have uric acid crystals that form in the toes, specifically the MTP, that's the most common area, those neutrophils are going to come in, they're going to try to eat those uric acid crystals, but they can't, and they die, and they start releasing their inflammatory mediators, and so you get this very intense reaction of pain and swelling and redness and warmth at that toe, at the NTP. And this thing is very, very painful. Patients are going to come in limping or maybe on a wheelchair because every time they put pressure on that toe, it's going to hurt. Even a bed sheet can cause a lot of pain with this. You can develop tophi. So tophi is just a precipitation of uric acid that happens in the skin. This is not painful because what happens here is that you get uric acid crystals that develop in the skin, but what the body does is it sends macrophages to cover it, right? Kind of like granuloma. You're not getting that inflammatory response with this, so that's why this is not painful. You can develop stones. We talked about that a few blocks ago, where this is the type of stone you can develop. If you decide to do a joint aspiration, which I don't know how you would, especially when how severe these patients are, as far as pain goes. But if you decide to do a synovial fluid aspiration, you'll see something called negatively bifurcated crystals. Essentially, you need a special microscope for this. This microscope looks at these crystals, and then based on the way it's oriented, they'll have a different color to them. So they may look yellow or blue, and that tells us that these are gout crystals. We treat these with NSAIDs, indomethacin, naproxen. That brings down the inflammation, and then maybe if we can't get them to change their life and lifestyle, then we'll give them medication that will lower their ability to make uric acid. Here's what that looks like. So toes, most commonly affected, those tophi in the ears, and then the crystals. All right, we're going to run through this real quickly. So we have benign tumors, so osteomas, which are essentially they're osteoblasts that keep putting down a lot of bone. That's what they are. They're benign, they're not going to turn into cancer, and so that's good. Chondromas, these are tumors of cartilage, and then non-ossifying fibromas, these are fibroblasts that are making these tumors. Bottom line here is that we may shoot an x-ray, and the radiologist may say, hey, you got this lesion that looks like an osteoma, or a chondroma or whatever. They're going to recommend to either get a better image like a CT or MRI and then track it just to make sure it doesn't change. Most of the time we don't do anything for these. We just, hey, you got this, we tell the patient this is benign, it's not going to turn into cancer, you're going to be fine. Sometimes they can cause pain, and so if they do, then we'll send them over to orthopedics where they can actually cut these out. I had a patient who had a chondroma in her scapula, and hers was causing her pain, so I sent her to ortho and they removed it. She was fine. But these don't turn into cancer, they're just benign tumors that can happen. These do turn, these are cancer, right? The big thing I want you to know here is that you got some that are associated with young folks, some that are associated with older folks, and they have certain characteristics in the way they look on x-rays. So Ewing sarcoma typically affects the long bones. It's going to look like onion skin. So the periosteum is reacting, so it's caught, so if you think about an onion peel, it's going to look like that. It's going to look like this kind of outer layer of periosteum, and I'll show you a picture in a second. We got to treat these, because if not, these patients will die. Osteosarcoma, this typically affects the metastasis. It looks like a sunburst on x-ray, typically near the knee, so it looks like a sun exploded. These patients, if we don't get them treated, potentially could die as well. And then the chondrosarcoma, these are older folks. These are, again, cancers of cartilage cells. They can happen anywhere, but most commonly in the pelvis of vertebrae. The problem with these guys is that because they're slow growing, chemo doesn't work as well for these guys. I told you guys, faster that a cell proliferates, the better chemo actually works. This is different. We have to actually cut these out because they don't work that well with chemo. So those are all primary cancers of bones. More commonly, you're going to get metastasis of bones. That's the most common thing you're actually going to see. So we'll talk about prostate cancer, how that metastasizes. Here's what that looks like. So osteosarcoma, that sunburst. Ewing's, you can kind of see that layer at the periosteum, and that chondrosarcoma, you can see it's kind of like lump stuff. All right, questions on that? Cool. I will see, or I think we got virtual Monday, so yeah.